Meet Si Ray, a 62-year-old Cambodian woman who suddenly feels a sharp pain in her chest while gardening. She struggles to breathe and feels a sense of tightness in her chest. She has been a smoker for many years and was recently diagnosed with emphysema, and had a previous heart attack around 5 years ago. She can feel her chest getting tighter and tighter. Not only that, but her heart is pounding in her chest. With every breath, she feels her chest getting worse. She eventually collapses and paramedics rush to the scene. What would be your differentials based on this history? As an extra clue, the paramedics noted her trachea shifted to the left. Is it an acute infarct, a tension pneumothorax, a pericardial tamponade, a ventricular aneurysm, acute anaphylaxis? There are features of each of these in her presentation, but the shift of her trachea indicates an acute tension pneumothorax. Given her history of emphysema, it is highly likely she has ruptured an emphysematous bully. The quick-thinking and highly trained paramedic does a needle thoracostomy and she wakes up almost immediately. Please watch our video on tension pneumothorax linked in the description below. But today we are concentrating on how to do a needle thoracostomy. Needle thoracostomy is performed in cases of tension pneumothorax, where air trapped in the pleural space puts pressure on the lungs and heart. By inserting a needle into the second intercostal space at the midclavicular line, healthcare providers can release this trapped air, providing immediate relief to the patient. While needle thoracostomy can be life-saving, it's not without its risks. Contraindications include certain chest wall deformities or previous surgeries in the area. Complications can range from injury to the lungs or surrounding tissues, to infection at the puncture site. The landmark used for needle thoracostomy is crucial for the safe and effective performance of the procedure. Here's a detailed description. Needle thoracostomy is typically performed in the second intercostal space at the midclavicular line on the affected side of the chest. Though some of the newer literature is advocating for it to be done at the same site as a tube thoracostomy, for this video, we will concentrate on current accepted norms and standards. Start by locating the sternal notch at the top of the sternum. Move downwards to the first bony prominence, which is the manubrium sternal junction or the angle of Lewis. This is the junction between the manubrium and the body of the sternum. The second rib attaches here. The space just below the second rib is the second intercostal space. Locate the midclavicular line. It is an imaginary vertical line that descends from the midpoint of the clavicle down the front of the chest. Find the midpoint of the clavicle and trace a line straight down towards the nipple. This is the midclavicular line. How do you perform the procedure? The area is cleaned and, if time permits, a local anesthetic may be used. A large bore needle, typically 14 to 16 gauge, which you may, or may not, attach to a syringe, is inserted perpendicularly into the chest wall. Pause, very often, especially in emergencies, a syringe is not used. Once the pleural space is entered, you will often hear a gust of air come through the needle. Sometimes air needs to be aspirated with a syringe, but this is more common in pediatric patients. Safety is always critical. You must correctly identify the landmarks to avoid injury to the heart, lungs, and major blood vessels. The procedure should be performed with a strict aseptic technique to minimize the risk of infection. The needle is inserted just above the third rib to avoid injury to the intercostal artery, which runs along the bottom of each rib, and in the second intercostal space at the midclavicular line, which you would have now marked. This position is chosen to avoid damage to the heart and major blood vessels, which are more centrally located. Very often you will hit a rib as you push the needle in. Run the tip of the needle superiorly along the rib, maintaining contact with the rib as you move, and it will move into the intercostal space as you pass the superior edge. Some of the most common complications are as follows. Failure to resolve the tension pneumothorax in obese or muscular patients. They may require a longer needle to reach the pleural space. In exceptionally large patients, you may have to proceed immediately to a tube thoracostomy, which we will discuss in an upcoming video. Iatrogenic pneumothorax. Laceration of intercostal artery or nerve. Rapid re-expansion may result in the development of pulmonary edema and infections if an aseptic technique is used. Thank you for joining us today at ER Mentorship Hub. We hope this insight into needle thoracostomy enriches your understanding of emergency medical procedures. Remember to like, share, and subscribe for more content, and hit that notification bell to stay updated. Every day is a chance to learn and grow in emergency medicine. Stay curious and stay informed.